all the viewers across the globe. Dr. Raj Sakhrekar here, and we have very special guest today, the most talented spine surgeon uh, from New York, Dr. Josie Coury. Dr. Josie is one of the youngest spine surgeons currently training with uh, Dr. Lenke in New York Presbyterian Hospital. To talk about Josie, she has received many awards and kind of research presentations, as well as lots of publications, more than hundreds. But the of many awards, the best award she has received, I feel, is the most hardworking resident, as well as distinction in research. Also, the award, the Lenke Award, for her phenomenal research during her career. There are many awards to come, but for now, we would love to hear more from Josie. In her spare time, she enjoys playing cello, she enjoys music, travel, skiing, spending time with family and friends. We welcome Josie for thank you for your time, and we're looking forward for your talk. Thank you.
Thank you so much, Raj. I really appreciate the invitation. I will start sharing my presentation now. All right. It looks like, can you see everything okay?
Yep, pretty good.
All righty. So Raj and I met back at SRS in Barcelona, where I gave a presentation on level selection in adult patients for idiopathic adult scoliosis. So it only made sense today to talk again about the Lenke classification, which founded it all, and then to talk about level selection in adolescent, as well as adult idiopathic scoliosis again. So I don't have any financial disclosures to tell you all, but it did seem important to mention when discussing the Lenke classification that I did my residency at Columbia under Dr. Lenke. I'm currently an adult spinal deformity fellow at Columbia with Dr. Lenke. And then next year, I'm going to be the dedicated pediatric spinal deformity fellow with Dr. Lenke. So pretty much all of my learning has been from him. So today, the outline for my talk, I thought I would first speak about the Lenke classification, then going into AIS level selection, where the biggest question is, when can you perform a selective thoracic fusion? And then go on, if we have time, to speak a bit about adult idiopathic scoliosis patients that are instrumented proximal to the pelvis. So first, starting with the Lenke classification. Prior to the Lenke classification, a multitude of scoliosis classifications were used. There was the King and Moe classification that was first developed in 1983, and at the time it was the gold standard for communicating AIS pathology for about 20 years. However, in 1998, a study came out that challenged the classification, where multiple major scoliosis surgeons found that it had really poor inter- and intra-observer reliability using that system. So later in 2001, the Lenke classification quickly emerged as a superior classification that had a very high intra and inter observer reliability, as you can see in these tables from the original study here. It's a relatively simple classification to use, and most importantly, it can help guide your fusion level selection. It can help guide how you think about a case for a patient. So to understand the basics of the Lenke classification, there are three important areas. There is the proximal thoracic spine, which has the apex around T3 to T5. There is the main thoracic spine, which is where there's an apex around T6 to the T11, T12 disc. And then there's the thoracolumbar or lumbar region, where the apex is between T12 to L4. So these are the three parts of the spine that we speak about in this classification system. The second important terminology to understand is what a major versus minor curve is. The major curve is the curve with the largest Cobb angle as measured by the end vertebra, which you can see in this AO spine foundation diagram here on the right. And how do you measure these Cobb angles? So measuring Cobb angles, the basis of all of this classification isn't as simple as you would think. There's been multiple studies that have shown that the variation in just measuring Cobb angles with academic spine surgeons can vary between 6 to 22 degrees. And I've seen multiple patients this year where they come to get a second opinion with Dr. Lenke, and we're told, oh, your curve is only 29 degrees. You don't need any additional x-rays or bracing. You'll be fine for the rest of your life. But when in reality, you measure their scoliosis and the curve is actually closer to 45 degrees and already in a surgical range. So a lot of time is spent in clinic with Dr. Lenke really accurately and precisely trying to measure Cobb angles. And so I thought that this would be a fun time to brag about the one time where I measured exactly the same to the second degree. 0.11. But it's really important to scrutinize your x-rays and make sure that you're measuring Cobb angles extremely accurately, because the variation in studies in the literature has been shown to be up to 22 degrees. And even before measuring Cobb angles, there's even other areas where there's room for error. So EOS imaging has been an incredible advancement in spine surgery, as it provides a low-dose radiation X-ray image of the entire patient's body while they're standing. But not a lot of people know that there's actually been a lot of prior studies about how you should stand in an EOS machine. And it's been determined that the optimal position to stand in an EOS machine is to have your arms flexed forward and have your fingertips leaning on your clavicle. So in the bottom left here, you can see that this is the image from the EOS technique. It's on their website posted for how you should stand inside of an EOS machine. And studies, some of these ones that I've listed up here, have found that when patients raise their arms or if they're leaning on something, that it can actually change their kyphosis, lordosis, and even reduce the size of their scoliotic curve if their hands are raised up above. But if you Google EOS image, these are some of the first 10 pictures that come up of patients in EOS machines, and none of these patients are standing correctly in the EOS machine. And of course, it's not their fault. It's just that the scrutiny of both Cobb measurements and how patients stand in an EOS machine is something that isn't always paid attention to, that it's important to when you're planning and classifying patients to take a second look at as well. So anyway, back to the Lenke classification system. So after you've measured your Cobb angles, you have to next determine what the major curve is, which is simple. It's what's the largest curve. Then after that, it's important to determine what other curves are structural or non-structural. And this is usually established with side bending films. So here's a patient where you can see they're bending to the left and bending to the right. This is the case that I'm going to use throughout this talk. Their main major curve is their thoracic curve, which is 58 degrees. Their proximal thoracic has bent down to about 18, and then their lumbar has bent down to 28. So anything that remains above 25 is considered structural. So clearly the lumbar curve is structural. However, it's not just the coronal plane x-rays that determine if a curve is structural in this classification system. And this is something that's also frequently overlooked. So on the sagittal view, if the kyphosis is above 20 degrees in the region of the curve, regardless of the coronal flexibility, the curve is also considered structural. So this patient does not have significant proximal thoracic kyphosis. It's about 16 degrees, but if it was greater than 20, it would be considered a structural curve, even if in the coronal plane it was only 5 degrees or so. So there's different regions that are measured for this. So in the proximal thoracic spine, it's intuitive. It's from T2 to T5 where you measure their kyphosis. But for both the main thoracic and the thoracolumbar, the kyphosis is measured from T10 to L2 for these patients to determine if the curve is indeed structural. So this is the summary of the curve types. I'm sure you all have seen this table before, but there's different names for which curves are major, non-structural, structural, minor. And the first three all have the main thoracic curve as the sole major curve. Type 4, it's a triple major, the main thoracic and thoracolumbar are both considered major curves. But in 4 through 5, the thoracolumbar curve is also a major structural curve. So that's part 1 of the classification. The next part of the classification is the lumbar spine modifier, which is where the CSVL, the central sacral vertical line, lies with respect to the lumbar scoliotic curve that a patient has. So here you can see in the left is a lumbar modifier A, where the CSVL is lying in between the pedicles at the curve apex for the lumbar curve. So it's bisecting the pedicles, it's within CSVL. In type B, the CSVL crosses at the pedicle, and then in type C, there's no contact with CSVL to the apex of the lumbar curve. The last modifier of the formal initial Lenke classification is the sagittal thoracic modifier, and this is measuring a patient's kyphosis. So in the left is a patient who is a minus, which means they're hypokyphotic. They only have 7 degrees of kyphosis. In the middle is normokyphosis, which is between 10 to 40 degrees. And in the right is hyperkyphosis, a patient who has over 40 degrees of kyphosis.
Okay.
So this, oh, sorry.
So we'll just summarize, Josephine, for the viewers. Very interesting the way you explained. first to go with the structural versus non-structural. If the structural curve on just the plain bending, the curve is 45, but on one bending it goes 35, and on other bending it goes to 10. So, do you consider that curve a structural curve?
That's an important point, and that's really the scrutiny of X-rays. So if it's on a standing film, if the like for this patient it measures 26 degrees and in an X-ray it measures down to 18, that's beneath, that's a non-structural curve. But I guess the question you're asking is if you have another bending film and it doesn't go beneath 20 is what you're asking. Would you still consider
Yeah.
it structural?
Yes, that's right.
That's a good point. I think that it's all evidence for you to take in, and it depends on the timing of the X-rays, the technique of the X-rays, because it is true. A lot of patients, you can tell in this example that I have here, you can see that the patient is really trying to bend. They're putting in a good effort to see how flexible their curve is. But sometimes you can tell that the patient's just shrugging their shoulders a little bit rather than actually fully attempting to bend. So it is important to look when you're measuring how much the Cobb angle changed, and you can get clues from the EOS image to see how much the patient is attempting to straighten out their curve for you. So good point. So I'd say it would not. I would look at what the X-ray looked like, and if it looked like the X-ray with the lower number, the patient was putting in a good effort to bend out their curve, then I think that's evidence that it's a non-structural curve if it's below 20 degrees, as long as they don't have kyphosis in the sagittal plane.
Very interesting. Thank you for clarifying the doubts. We can go ahead.
All right, yeah. So this is the case that I was showing a little bit. So just to put together this patient's measurements. So because the proximal thoracic curve is non-structural and the thoracolumbar curve is structural, this patient gets the classification of a Lenke 3 and then B because it's touching at the pedicle in the lumbar curve, and then N because they have normal kyphosis. They only have about 36 degrees of kyphosis. So there are a couple of modifiers to the Lenke classification that come up. The first one is the last touched vertebra or the touched vertebra. The touched vertebra is the most cephalad thoracolumbar or lumbar vertebral body that is intersected by the CSVL on standing upright films. And this is something that we're going to talk about throughout the rest of this talk because it's very important for LIV selection, which I know that we wanted to all talk about today. But the touch vertebra is the same as LTV, TV, LTV. People use them interchangeably. And there's been a multitude of studies that have shown, and recently this study here with minimum 5-year follow-up, that it's a very reliable technique to decide on your LIV. So we'll talk more about it later, but just to introduce the concept of this as a modifier, the last touched vertebra. Another modifier is the sagittal stable vertebra. This is the most cephalad vertebra that is intersected by the PSVL, the posterior sacral vertical line, on a sagittal X-ray. And there's also been a multitude of studies that have shown that including the SSV, the sagittal stable vertebra, in your fusion construct can prevent DJK for these patients. And then the last modifier, which Raj and I were just speaking about offline, is the AR and AL modifier, which is unique to the Lenke type 1 and type 2 subtypes. It was developed or noticed, I guess, in 2008. And it's basically looking at the L4 vertebra, like you can see in this picture here on the left. And in the AL subtype, the L4 vertebra is tilting off to the left. And in the AR subtype, the L4 vertebra is tilting off to the right. And while I think that this is a very helpful technique to look at and pay attention to what's happening in the structural curve below, it's also important to notice that other factors are still different between these two patients. So it's not just the L4 tilt. If you look at where L3 is, in the patient on the left, L3, the L3 body is flat on top of L4. And in the right, where it's L4 is tilted off to the right, there's a really large disc wedge that this patient has. But in general, the significance and importance of this is that patients who have a right tilt more frequently require a more distal fusion to achieve an optimal correction and prevent adding on, as compared to patients who have an AL tip, which you can see here. This patient's last touch vertebra is L1. This seems much more favorable for a shorter fusion construct. So Cho et al. Found in a later study that patients who have this right tilt of L4 were 2.2 times more likely to have distal adding on than if they had a left tilt. So now that we've gone over the Lenke classification, now to talk about how this actually applies. And the biggest question that I think people use this classification for, which is when can you perform a selective thoracic fusion for these patients? So the general steps in planning AIS surgery, first, of course, is to determine the Lenke classification, which we just went over. Second is to decide on the regions to include in the fusion construct, the selective thoracic fusion, if that's possible. And then 3, to actually go through the weeds and decide on which UIV and LIV you should select for your patient. So looking back to my patient, this Lenke 3BN that we just went over, would this patient be a candidate for a selective thoracic fusion? And technically, a Lenke 3 patient has a structural lumbar curve. And we know that for structural proximal thoracic curves, they always have to be included in your fusion construct. But for this patient, do they actually have to be instrumented all the way down to L3 or L4 since it's a structural lumbar curve, or can they be a candidate for a selective thoracic fusion? How do we determine this? So there are 3 techniques to determine if a patient is a candidate for a selective thoracic fusion. And these techniques have actually been around for a long time, but they still are great rules and they work really well. And we'll go into the 3 of them now today. So the first is the apical vertebral rotation. And this is based off of Nash-Moe grading, which you can see actually this original paper is back from 1969, the study of vertebral rotation by Nash and Moe. And so this image on the middle is their sketch from the original article, where you can see a grade 1 is when the pedicles are both en face, you're looking directly at them. Grade 2 is as the pedicles start to disappear and rotate, and then all the way down here, it's a grade 4, but you count it as the number 5 when you're doing the AVR, apical vertebral rotation ratio. So anyway, so you look at the apex of the main thoracic curve, you look at the apex of the lumbar curve, and you determine what grade of rotation each apex has. So in this patient, the apex in the thoracic was a 3, and in the lumbar was a 2. And when you have a ratio of greater than 1.2, basically that the rotation isn't the same between both 2 curves, that is favorable for a patient to undergo a selective thoracic fusion. And interestingly, this doesn't just have to be performed with Nash-Moe grading and x-rays. You can actually perform this analysis clinically by using a scoliometer, by measuring a patient's rotation in their thoracic and lumbar curve, and then again, just simply performing the ratio of the thoracic to the lumbar curve. Or if you have a Lenke 5 or 6, comparing the lumbar to the thoracic curve. Apical vertebral translation is the distance from the C7 plumb line, as you can see in this patient on the left, to the center of the apex of the thoracic curve and to the lumbar curve, and then once again comparing that ratio. So it's again just simple division. For this patient, it's 32 millimeters compared to 5 millimeters, which gives an AVT of 6.4. So when the AVT is greater also than 1.2, if it's translated over 20% or more, this is also a patient that can be treated with a selective thoracic fusion. It's also favorable for a selective thoracic fusion. The last ratio is just simply the Cobb angle ratio, which is where you measure the Cobb angle from the major curve to the other structural minor curve. And again, if the ratio is above 1.2 or the main thoracic curve is 20% greater, the patient is appropriate for a selective thoracic fusion. So it's nice, it's all pretty consistent and easy to use and apply. So before I go on and talk about our case, I also think it's really important to note the contraindications to doing a selective thoracic fusion. And the first one, which is a mistake that I think we see a little bit too infrequently sometimes, or too frequently sometimes, is in highly skeletally mature patients. If a patient has open triradiate cartilage, a low Sanders, Risser 2, they should not be a candidate for a selective thoracic fusion as they have high risk for distal adding on. Another thing for just surgical technique is that if the shoulder depression is ipsilateral to the thoracolumbar curve, that sometimes a selective thoracic fusion can actually exacerbate that deformity. Also for patients who are coming to you because they have an unacceptable lumbar hump or waistline asymmetry, you would think that this would be caught by the rotation angle, by the AVR ratio, but sometimes it's not. And if that's something that it's really important to a patient to have corrected, a selective thoracic fusion is not always the answer for them. And then the last is that if a patient has a connective tissue disorder or an elevated Baton score, if they're highly flexible, doing a minimal selective thoracic fusion also is not a good option for that patient as they are at high risk for adding on. So looking back to the patient I just showed you, this patient had a selective thoracic fusion. This patient had an LIV of T12, and these are her x-rays at 2 years post-op with an excellent alignment. There was a study of 21 patients with Lenke 3C curves who underwent selective thoracic fusion, who met at least 2 or 3 of these criteria, and all of them went on to have excellent post-op outcomes. So this just goes to show you can do selective thoracic fusions for structural lumbar curves as well. And then one more example, this is a even more drastic example, a patient that had a Lenke 3CN where their lumbar curve was 51 degrees. But if you go through the ratios, their Cobb ratio is 1.3, AVT is 2, AVR is 2. The scoliometer, the main thoracic curve degrees was 17, lumbar was 12, so 1.4 was that ratio. So this patient would be a candidate for a selective thoracic fusion, even though when you look and you draw your CSVL, the last touched vertebra for this patient is L4. So you're looking at between fusing just their main thoracic curve or going all the way down to L4 for their LIV. But so this is the patient here post-op. She had her right shoulder was slightly elevated, so she underwent a fusion from T4 to T12 and had excellent radiographic outcomes. And you can see actually clinically here too that her lumbar rotation actually improved. So she was favorable for a selective thoracic fusion. So now that we've talked a little bit about selective thoracic fusion, I was going to go into the details of exactly which UIV and which LIV to select for these patients. UIV is a little bit more straightforward. I feel like UIV, most of us have got down at this point. So there's this few different factors that go into deciding which level to use. There's, first of all, shoulder balance, which we'll look at the classic shoulder balance rules next. The size and the stiffness of the proximal thoracic curve. So if you have a structural proximal thoracic curve or kyphosis above 20 degrees, you always have to go to T2. That's a good, straightforward, simple rule. And then the amount of the correction in the thoracic spine that's planned. If a really major correction is planned, an 80, 90 degree curve, sometimes it makes more sense to go up to T2 to have more fixation points above the fusion construct that you've planned. So here's just a study showing some clinical images of how you can assess shoulder balance with clavicles. But in general, the rule is what we've all heard. If the left shoulder is higher than the right, you go up to T2. If the shoulders are level, then you go to T3. And if the right shoulder is higher than the left, then you go up to T4 for your UIV. So here are just a few examples of patients where the left side was highest on the left there. So T2 was used as the UIV. In the middle, the patient was level. They had level shoulders, and post-op, after going to T3 as the UIV, the patient still had level shoulders. And then in the far right, the patient had an elevated right shoulder, and T4 was used as their UIV. So there's a couple other things just to pay attention to with shoulder balance. So looking at the individual vertebral bodies on the coronal films, it's important to note that here in this patient, they have a lot of tilt at their T4. So even though the right shoulder might be a little bit high in this patient, T4 might not be the best UIV because of how tilted and rotated it is. So when you're planning your UIV, it's good to also scrutinize, look at the tilt, rotation, the pedicle sides, and if you do disobey the shoulder rule, to just be mindful of that during your correction. If your right shoulder is high, to not overcorrect and push up the right shoulder even more. And again, to always pay attention to the proximal thoracic kyphosis. Okay.
Just to add on the UIV, the tilt, some surgeons and the articles also, if you could show the previous slide, Josie.
Yeah, absolutely. Thanks for chiming in. I know, I feel like it's
So if the inclination of the T1, the next one, yeah, is very important factor. If the T1 inclination is more towards the right, then the structural curve is right itself, and you can consider stopping at 3, 4, or 5. That means the main thoracic curve is the structural, and the proximal thoracic have less significance. But if the T1 inclination is towards the left, or its level, then it means the proximal thoracic curve is playing a major part, and you want that inclination to be leveled or go other side, because you're going to kind of distract the concave side of main thoracic. So it will going to unbalance the shoulder more. So T1 inclination along with the other factors are also important, deciding the upper instrumented level. That's it. What do you think about that, Josie?
Absolutely. No, that makes a lot of sense. And people all, it's funny how I feel like surgeons all look at different things too when they're assessing shoulder balance. I find that Dr. Lenke looks most frequently at the clavicles, but a lot of people look more at T1's angulation. People look more at the acromions. They look more clinically at their shoulder balance. There's lots of different ways to assess shoulder balance. And I think, yeah, T1 angulation is definitely an important way to look at it. And it's also been interesting to see this year too that I find that I think getting shoulder balance perfect as well as you can in the OR is an absolutely great goal to have. But it's funny that the patients can actually adjust their shoulder balance. You would be surprised, as I'm orthopedic trained. A lot of our spine surgeons are neurosurgery trained, but you can move your entire shoulder by your shoulder girdle muscles. And a lot of the times, if a patient's unhappy with their appearance, over time with physical therapy, working on their trapezial muscles, shoulder girdle muscles, you can actually rebalance your shoulders a little bit on your own too. But of course, it comes structurally from the spine as well, from your angulation that you have in your proximal thoracic curve. But it's something that patients can surprisingly compensate for too over time. Shoulder balance does change. What it is immediate post-op is not what it is at 2 years post-op. So,
That's very interesting. Thanks for your thoughts on that.
all
We can move
right.
on. Yep.
Yeah, we can go on to LIV selection. So I have LIV selection, and then I have a bit on adult idiopathic scoliosis too, if we have time. I want to talk about that as well. So LIV selection. LIV selection is far more nuanced than UIV selection. And really what we talk about the most at Columbia is still just the Lenke rule, the last touched vertebral body, the LTV. But there's a lot of other things that you should pay attention to, like the amount of rotation that you have at your LIV is important to look at, the amount of angulation, where the disc is wedged below. It's also important to look at what I mentioned before, the stable sagittal vertebral body, the most cephalad vertebra that's intersected by PSVL. And while this was originally described for Schuermann's kyphosis, there's been studies showing that it applies to AIS as well, to scoliotic constructs too. And then the other thing to note is when you're planning fusion levels and looking at your LIV, to have a balanced construct. In general, it's good to have equal levels above and below the apex of the curve that you're correcting. And if you're cutting it short for your LIV and have an unbalanced construct, that can absolutely lead to distal adding on for these patients. And then the last is, again, it's always important to pay attention to the proximal thoracic kyphosis for UIV. So you also have to pay attention to the thoracolumbar kyphosis for the LIV. So a bunch of recent studies have also shown that the last touched vertebra on supine films can be used as the LIV and AIS. So there's a study from Kim et al. In 2022 that found that when a patient lays supine and you just, rather than bending films, just supine films, look at the last touch vertebral body, that potentially that can be used as LIV as well in AIS in skeletally mature patients, not very highly skeletally immature patients. And that can be a reliable last instrumented vertebral body for patients. But relative to the contact of the TV on supine films is this concept of substantial contact. And this was introduced by Cho et al. And it's really also kind of a part of the lumbar modifier too from the original Lenke classification. But basically, substantial contact is a Lenke B modifier, or A. It's when the CSVL intersects at the pedicle or is medial to the pedicle. As you can see in this patient, right here at the pedicle, here it's medial to the pedicle, as compared to when the CSVL intersects lateral to the pedicle. That's considered not having substantial contact. But a few studies have actually shown now that those patients who are using an LIV that's touched lateral to the pedicle have an increased risk of distal adding on, that it's almost 2 or 3 times increased, that they can crankshaft below their construct if CSVL intersects lateral to the pedicle. So this is an example of a patient. This is a Lenke 4. This is a triple major patient where their last touched vertebra is L3. And you can see here, this is a pretty favorable LIV for this patient for a few reasons. So one, I should have shown the supine films too, but here, even on standing films, you can see that CSVL crosses at the pedicle. This L3 LIV has substantial contact. Also, even though this is a rightwarded tilt for this LIV for L4 and L3, you can see that there's a large disc wedge off to the side of the curve here for this patient. That's also favorable for stopping at L3, that this disc wedge can be utilized to level out the LIV for this patient. It's tilted in the right direction to level out. So you can see here now that post-op, after a series of compression, distraction, the L3-4 intervertebral disc is perfectly level in this patient. This is 2-year post-op x-rays as well. But in this 100-degree curve, where a lot of people would probably be frightened to stop at this very tilted L3, because it's touched at the pedicle, because of the disc wedging, not too much rotation at this vertebral body. And you can see that this person has closed triradiate cartilage. They're more on the edge of skeletally mature. She's a 13-year-old girl. That L3 was an appropriate LIV for this patient.
So just to spend a little more time there, like this is a very important slide, and thanks for sharing, Josie. So that's what always the confusion is there, L3 versus L4 in this Lenke 1R curves. If you see the disc opening, it's the opposite side of the apex of the curve. And if on the bendings, it's kind of flexible. It opens and closes on bendings. So in that type of curve, you can definitely stop at L3 because by compression distraction, you can level up the disc
Exactly.
as level as the pelvis, and it will have a very good result. So you can save the levels of fusion and keep more mobile segments. So fusing till L3 is quite adequate in this type of curve. Very well said, Josie. Thanks very much.
Exactly. Yeah, absolutely. And it's all the little things. It's, it's easy to say, okay, last touched vertebra, that's what we'll use as LIV, but it's important to really scrutinize how the CSVL is touching that last vertebra. And that's what's so important for this patient, that there's intersection at the pedicle, that it's not a true stable vertebra, which would be intersection between the two pedicles, but it's touched substantially, which is a great concept introduced by Dr. Cho. And originally it's the same as the lumbar modifier from Dr. Lenke. So this is just one more example. This is also a patient where the last touched vertebra was L3, and that you can see this is one where I wanted to include the supine films, that the supine films can really give you some more information as to whether this is an acceptable LIV for this patient. So this is an AIS patient, and you can see on standing films, there is good substantial contact to L3. It is touched at the pedicle, but that when the patient lies supine, it really becomes a stable vertebra, that at L3, it's intersected now in between the two pedicles, and that this is a very appropriate LIV choice for this patient. And you can see here, this patient also at 2 years post-op with L3 is an excellent LIV for this patient. But again, I think that if you take away CSVL and you don't scrutinize the L3 vertebral body, you would look at the tilt of L3, you would look at the size of the curve and think, I don't know if L3 would be an appropriate UIV. I want to play it safe and stick with L4. But the supine films give you a lot more information as well, that it has substantial contact, it's a stable vertebra, and it's appropriate for an LIV selection. There's been a few studies that have shown that when you fuse proximal to the last touched vertebra, it cannot be a good situation for patients. So this Matsumoto study found that the risk of adding on was 6.7 times more likely if the last touched vertebra was not used as LIV. This cow study also found that patients who were fused proximal to the LTV had a significantly increased risk of adding on. And then this more recent study by Murphy et al. Also found that in the 3 biggest risk factors for distal adding on in scoliosis AIS patients was 1, fusing short of the last touch vertebra that had substantial contact. They also paid attention to whether if it was touched at or medial to the pedicle, if they were skeletally immature, which we already spoke about. And then they also have this other concept they introduced, that if a patient has very, very good coronal alignment preoperatively, that you can overcorrect them, and that postoperatively they can have a risk of malalignment. So all important things to pay attention to. And that also in this study, if a patient had all 3 risk factors, they had an 80% chance of distal adding on after surgery. But another caveat that we really speak about a lot now at Columbia in our pre-op conference is the sagittal plane. It's really important also to look at the sagittal plane and look at the sagittal stable vertebra, which again was originally a Schurman's kyphosis variable, but it's really important also for AIS to include the SSV in your fusion construct. So this is an example. This is a little bit older of a patient, a 18-year-old boy, where you look in the coronal x-rays and the last touch vertebra is L1 at the pedicle. And then when you go supine, it's T12 touched at the pedicle, which is very tempting to use as an LIV. But in his sagittal plane, he has a negative C7 SVA. And you can see that his SSV is actually pretty low. It's L2 for this patient. So that's why for this patient, Dr. Lenke elected to go to L2 as the LIV, even though it was very tempting to push it and go up to T12. But one of the other things that we always talk about, which is what you brought up, Raj, too, is that it's important when you're deciding between LIVs of L3 and L4. But when you're looking between T11, T12, L1, L2, there's not that much of a functional difference for your average patient. You can still have excellent lumbar motion with an L2 LIV, and it's much more important to make sure that your patient is not going to have adding on and come back for surgery than preserve a very small 5% of their lumbar motion, since we all know that most of your lumbar motion comes from L3 to S1 as compared to T12 to L2. So when you're looking between those different LIVs, it's most important to do what's right for the patient and not try to push it to save one level that functionally and clinically doesn't make as much of a difference for a patient. So that concludes for the Lenke type 1 to 3 curves. I also just wanted to briefly mention Lenke type 5 curves and all of the rules that we spoke about, AVR, AVT, Cobb ratio, those all apply when you're looking also at the structural lumbar, thoracolumbar or lumbar curve. And then the other concept that really applies to the Lenke 5 and 6 curves is because you're not using shoulder balance rules, you're not using shoulder balance rules to decide on your UIV, really the most important thing that we speak about is having a balanced construct. This is where that concept really comes into play, to go 3 levels above and 3 levels below the apex. So for this patient, their apex was the T12 L1 disc, so they were fused up above to T9 and then below to L4. So you can see they have a very balanced construct. And really excellent alignment here again, 2 years post-op. I always show pre-op and 2 years post-op. But one important concept that we studied with the Lenke 5 and 6 curves is that these patients have a really high rate of PJK. And when they undergo selective thoracolumbar and lumbar fusions, not when they have a full T2 to L4 fusion. And in some studies in the literature, the rates are reported as high as 50%. And so we did a study with the HARMS database, which had 192 Lenke 5 and 6 curves, which, as we all know, this is a more rare curve subtype. So this is the largest study of Lenke 5 and 6 curves that's been published now. And we found that all 17 of the patients in this database who had PJK had a UIV that was within 3 levels of the thoracic kyphosis apex. So once again, looking at the sagittal X-ray is really important. So these 2 patients who went on to have radiographic PJK, which isn't so terrible. As you can see here, 30 degrees, it's when you first glance at it, it's hard to imagine that it truly is PJK, but it is if you measure the PJA from pre-op to post-op. But this patient was fused just 1 level below the apex of their thoracic kyphosis. And this patient was basically fused at the apex of their thoracic kyphosis. So it's also important to pay attention to where your UIV is on the sagittal plane in Lenke 5 and 6 curves, because we did find in this study, although frequently people say that radiographic PJK is not always symptomatic in these patients, we found that at 5-year post-op, because this had a 5-year follow-up in the HARMS database, these patients had significantly lower self-image scores and function scores for their SRS scores. So although they're not coming in saying that they have back pain and that they're symptomatic, these patients feel much worse about themselves and cite that they have lower function when they have radiographic PJK in their thoracic spine. So for these 2 patients, it might have made more sense to go all the way up, to go up to T4, to go up to T3, to make sure that you're above the thoracic kyphosis apex rather than below, because in the coronal plane, if you could imagine this was a coronal X-ray, you would never stop just 1 below the apex of their coronal deformity. But in the sagittal plane, we tend to do that all the time. So it's important to pay attention to sagittal X-rays.
That's a very interesting point, Josie. Crossing the apex in the sagittal plane is very important to prevent the PJK, even if it's the chances of radiological PJK is 100%. The clinical scenarios, it will be 15 to 30%. So always cross the apex of the thoracic curve in the sagittal. And also talking about the, if you could move back to one slide. So technically, we all most train posterior only by approaches, all the surgeons across the globe, but there are few surgeons who do anterior too, and there is a lot of discussion about doing anterior surgeries for Lenke 5 and 6. And few advantages of anterior versus posterior here is the anterior surgeries will have less number of fuse levels, which is most important and significant factor, that less number of fusion levels, because the amount of correction with the disc release we achieve is quite uh, significant, as well as less muscle atrophy because we are avoiding to go through the posterior muscles, less blood loss. A few literature talk about the posterior versus anterior are equal, but some other literature talks the anterior is slightly better than the posterior. So that's the only point when we are discussing about Lenke 5 and 6 we want to add. What do you think about this, Jose?
Yeah, no, that's a great point. And I've seen some of those studies too, where exactly they showed that in anterior approaches that you could use an LIV that was above LTV and that they still had pretty excellent radiographic outcomes. And yeah, it's interesting to see. We use an all posterior approach, pretty much every surgeon at Columbia, just because it's a safe approach. You're not seeing any of the abdominal organs or major arterial vessels. And that you can get a really excellent correction posteriorly as well too. And it depends on the approach and how the anterior release is done, but I've seen a few tethers now, and the whole purpose of scoliosis surgery is to preserve a patient's lung volumes. Of course, it's also their alignment and their pain, but it's really to preserve their pulmonary function. And it's just hard intuitively to do an anterior approach, to take down the lung, to cause all kinds of pleural scarring and bleeding, when that's really the goal of the surgery. So I think that's why we've kind of shifted to an all posterior approach for our patients. But I'm definitely interested in learning more, and I think that is a big part of the future of doing minimally invasive anterior surgery. Maximizing and minimizing the fusion levels, maximizing mobility. So it'd be interesting to learn more about the anterior approaches. So thank you for including that as well too. And I wish I had more to say about them, but I haven't done any anterior approaches aside from tethers. So,
Well, that's a very interesting thought, Josie. We can move ahead.
all right. This was just a summary table of how to select if a selective thoracic fusion or a selective fusion is appropriate, and then how to decide on your UIV and how to decide on your LIV for these cases too. So the last part of the talk, just the last thing to include, I see we are getting up to about 40 minutes or so now, is I just wanted to talk again about my presentation at SRS this year, and just to show the podium that we presented on whether or not you can use the last touched vertebra concept in adult idiopathic scoliosis patients. So these are patients who likely had idiopathic scoliosis as a child and then went on to become adults without treatment, and it either progressed or was not identified. So this is an algorithm that we created and is in the article that we're publishing. So, of course, if a patient has symptomatic lumbar spinal stenosis, if they have significant facet arthritis and spondylosis, if they have spondylolisthesis, or if they have sacroiliac dysfunction, of course, they're going to need pelvic fixation. They'll need fixation to sacrum and ilium for their fusion construct. So those patients are not even a part of this study, patients with symptomatic lumbar spine. But our algorithm was to then look at the last touched vertebra as a candidate for the LIV in adult idiopathic scoliosis patients, because it seems that there's almost a bias that all adult idiopathic scoliosis patients need to have pelvic fixation because of that risk of going on to have a degenerative lumbar spine. So we performed a retrospective review of our single patient population at Columbia, which was 66 patients that had idiopathic scoliosis, adult idiopathic. The average age was 29, and they were all treated with a posterior approach, which we were just speaking about, and all had a minimum 2-year follow-up. And we had two groups that we looked at. We looked at patients where the touched vertebra was the same, exactly the same on the upright films as the supine films, because that's something that we really like to pay attention to now for patients. And then in group 2, we looked at patients where when they laid supine, their touched vertebra moved cephalad, that they had flexibility on their coronal films, even though they were an adult with idiopathic scoliosis, that they demonstrated radiographic flexibility. And within that group, we had 3 separate subgroups. So we had a group where we still used the standing last touch vertebra. We had a group where we used the supine touched vertebra and it had substantial contact. And then we had a last group where we used the supine touched vertebra, but it did not have substantial contact. So we determined that a patient was fused to an optimal LIV in 3 ways, 3 pretty standard ways. We looked at the C7 trunk shift post-op. We looked at the distance from the CSVL to the LIV. we looked at the distal disc angle, which was the disc angle below the LIV, as you can see demonstrated in this image here. So in group 1, that was 21 of our 66 patients, where this one you can see, for example, this is the patient on upright films and supine films, and not much is changing. This patient does not have much flexibility. Their last touch vertebra is still L1, and it is still intersected just exactly at the pedicle. These are actually 2 separate patients. And when these patients were fused to the touch vertebra, their last touch vertebras, their LIV, they all had excellent radiographic outcomes. So this is an adult idiopathic scoliosis patient. This is a 36-year-old, I believe, who at 5 years post-op did not have any distal adding on, did not require any revisions, and was fused to L1 as their LIV. In group 2, this was actually 45 of the 66 patients who demonstrated flexibility on their supine films. So I think more patients than you would expect that still had significant flexibility in their scoliosis curves when they laid supine. So these are 2 patients where on upright films, the curve is a very large magnitude and the LTV is barely L4, but then on supine that it's L3 touched at the pedicle. Same for this patient here too. Her lumbar curve really changed from upright to supine films, demonstrating the flexibility in adult curves. So here's that patient I showed on the right, who, even though she demonstrated flexibility for some other factors, potentially her body habitus, and then also how large the curve is on upright films, she was still instrumented to L4 as her last touch vertebra, and she had excellent radiographic outcomes also at 5 years post-op. This is group 2. This is a patient where their last touch vertebra shifted to L3 and was touched at the pedicle. And then this is the patient at 2 years post-op. Because the last touch vertebra that we used, even though it was on supine films, had substantial contact. So you can see here on the upright films, it's barely touched, but on supine, it has substantial contact at the pedicle. The patient had an excellent radiographic alignment at 2 years post-op and did really well, had a great correction. But the only patients that we saw, all the last 3 patients I showed you, all 3 groups, they all had excellent radiographic outcomes, and there was no significant differences between those groups. But we did find, looking back at our patients who we wanted to spare them a pelvic fixation, we wanted to spare them L5 as an LIV because L5 is very challenging LIV. We went to L4, and this is a patient where the last touch vertebra on supine films was L4, but you can see it was touched lateral to the pedicle. You can also see that there's so much rotation at the LIV. So this patient was instrumented to L4, and while it looks pretty good, if you zoom in, they have a really elevated distal disc angle of about 5 degrees, and they're developing a lot more spondylosis and low back pain. So in this patient group where the last touch vertebra on supine films is used but does not have substantial contact, it's not always the best LIV for adult patients. But so you can use the touch vertebra concept that we spoke about just now for AIS. You can also use it in adult idiopathic scoliosis as well. But it's important to pay attention to, like I showed in that algorithm, if they have symptomatic lumbar spine, stenosis, spondylosis, spondylolisthesis. And but you can use them if they have substantial contact at their last touch vertebra as their LIV. So just a quick conclusion, and then we'll talk some more. So we went over the Lenke classification. We went over AIS level selection, when you can perform a selective thoracic fusion, how to pick a UIV and LIV. We talked a little bit about adult idiopathic scoliosis and selecting an LIV proximal to the sacrum, but it is so much to cover in one talk. And that's why Raj and I are doing fellowships, because there's so many nuances to this. There's so many things to talk about, and each patient is different, and you really have to weigh your goals with the patient. It's really LIV that's the most important, maintaining as much motion as you can for these patients, but also performing a safe correction so that you're not going to be back taking them to surgery again. So I just wanted to say briefly what I think the future directions are. And I asked ChatGPT to give me a picture of the future of spine surgery, and this is what it gave me. Pretty interesting. I guess it's showing a lot of augmented reality, and it looks like a robot's maybe doing the surgery on the left. So a little bit scared of what ChatGPT is envisioning. But what I envision is that the classification systems would be 3D rather than 2D, that we could have more 3-dimensional imaging using more. I know that a lot of institutions are using gait labs now to classify and to look at a patient's center of gravity, to look at their cone of economy when they're actually moving rather than just on static x-rays, because of how we spoke in the beginning, what we spoke about in the beginning of the talk, that the way you stand in a EOS machine completely changes your x-rays. You can really change your position. So it'd be important to actually measure dynamic imaging for these patients and have a classification that's based on how they live their everyday lives. and that we could use that to actually choose level selection for these patients, and that hopefully someday tethering can be even better and we can all perform motion sparing procedures for these patients to have tethers that don't break and they stay in place forever, or that they perform true growth modulation and then break. So just a few things. And then thank you to all my mentors. I'm at Columbia with Dr. Lenke, but I've also been really close with Dr. Vitale, who I'll be with next year during my Peds Spine Fellowship, and then also with Dr. Sardar. And here's some of my social media and my email if anybody wants to reach out to me if they have any questions or thoughts that they want to share. I'm always interested what other people have to say, and I hope I have some opportunities to go around the world and watch how people are doing things in other parts of the world. So thanks so much, Raj.
Oh, it's a brilliant talk, Jose. Phenomenal. You included all the important points, and we discussed the most crucial points. And the audience, or the message I'm already getting, absolutely loved it. It's phenomenal. Thank you for accepting invite, and it was a really great talk. Just if Dr. Hassan or Dr. Pineda have any questions, we can include them. Dr. Hassan, any questions? Dr. Pineda, any questions?
He's one of the Dr. Lenke's, or he is Dr. Lenke's research coordinator and the head of spine research at Columbia. So all the projects that I presented today, he was a part of with me. So thank you, Fatih, for all of your help with everything and your support.
Amazing. I think they're muted. So you want to discuss any points, any further discussions, Josie?
I know we've spoken a bit offline about the AR and AL. I can go back to that a little bit because I think it's just interesting now that we've gone through the whole talk to look back at that again one more time. Let's look at this. Let's see where's the best. I'm just going to look back at this again. So maybe hopefully now after going through the talk, you could see, I think the more that you talk about x-rays, and I really encourage if your institutions don't have it, at a lot of the institutions I've been to, there's a pre-op conference, and we have 2 a week actually at Columbia. We have one Monday morning for our adult patients, and then Thursdays for our pediatric patients, and every single surgeon comes bright and early. Dr. Lenke's there from the neurosurgery side, Dr. Chow is there, Dr. Chan's there, Dr. Mandigo, Dr. McCormick, Dr. Lehman. Everybody comes to our conference and we all look at x-rays and the planned surgeries together. And it's so educational as a fellow. The residents come, all 20 of us are sitting in a room and we stare at our x-rays together. And that's how I learned all of this, to hear the masters of spine surgery talk about when you're comparing these two. And I actually really haven't heard either any of the attendings, Dr. Vitale, Dr. Roy, really focus on the L4 tilt, because what they zero in on is what's happening at the last touch vertebra on upright films like these, and then comparing that to supine films. So I think it's very useful. It's an important thing to look at too, to pay attention and look at the difference at L4 between these two x-rays. But again, you can look at the difference between these two x-rays at what the last touch vertebra is. So in this Lenke type 1 AL, the last touch vertebra is up here at L1, or is this even T12? No, L1. And then here on the right, that the last touch vertebra is barely L3. It's barely touching at the pedicle. So you can see what a difference the L4 tilt makes in what the last touched vertebra is. And Dr. Lenke also talks about how it's helpful to have things be simple. It's helpful to have one thing that you always look at and always pay attention to, because there are hundreds and hundreds of articles about LIV selection and everybody's approach to LIV selection. And the truth is that all of them work. All of them are great. And this patient population does really well after spine surgery. And that if you have a good, safe technique, and that if you really communicate with your patient and plan with them, that pretty much anything you do is going to work out pretty well for these patients. But for us, and for how I think about these cases, I always just look at the last touched vertebra. That's the first thing I look at. Which vertebra is the last touched, and how is it touched? Is it touching at the pedicle? Is it lateral to the pedicle? Then I look at their clinical deformity. I look at how much skeletal maturity they have. I look at the rotation of the LIV. That's kind of what comes into my algorithm, to pick the last touch vertebra, and then to pay attention to all the other factors to make sure that makes sense to have as an LIV. So just talking at that again.
Very interesting. Dr. Pineda, do you have any questions? Dr. Pineda's hand is raised.
Yeah, sure. Thank
Yes.
you. I just want to say congrats for the lecture to Dr. Josephine. Right now, I'm here in Colombia. So just want to say thank you for the invitation. My question is, the Lenke classification for adult idiopathic scoliosis, it used standing and supine X-rays. But in 2007, Professor Lenke published an article about supine X-rays instead of bending X-rays in adolescent idiopathic scoliosis. I don't know if currently they are still doing this in adolescent idiopathic scoliosis.
Yeah,
Just
that
standing and supine, not bending.
exactly. That's a great question. And I was debating whether or not to get into that, but that's exactly right. And that's when we are getting our preoperative x-rays, this is what we get. We actually don't always get bending films anymore because of what we spoke about earlier, Raj, that the way the patient bends makes a really big difference how much effort they put into it. And it's definitely helpful to see how flexible a patient is. But actually, you're right. Dr. Lenke now really just looks at the supine films, and the supine films can give you enough information to see how much a curve is bent out, and it can probably give you the same amount of information as bending films. So this is what typical pre-op imaging is for us, the supine coronal x-ray, and then we measure the curves on that as well. And it's not the original Lenke classification. It's supposed to be side bending films, but just plain supine films can give you all the information you need to classify a patient and to determine if it's a safe last touch vertebra. So thanks for bringing that up. I should have put that study in here too, but it's very true. You don't really need to have side bending x-rays. They're difficult to perform. Not all institutions can do them well. It's dependent on the effort the patient puts in, and it's nice to standardize things as much as you can for these cases. So great point.
Thank
So
you. Thank you so much.
very interesting fact, Dr. Pineda and Josie. So in cases where bending films are not, we are not, if you are not doing it, then definitely along with the plain standard AP X-ray standing, we can do the supine X-ray also. If in case we don't have the bending X-rays, that's definitely one of the takeaways for the audience.
Exactly. It's a great point.
Well, any other questions, Dr. Hassan?
Maybe one, just the last
Sure.
one, I promise.
Pineda, yes.
I see that in all your pictures, you perform high density construct. It's any different with the selection of the last instrument vertebra between high density or low density?
That's an excellent point. And that's also something I've noticed too. I actually went on an international trip with Global Spine Outreach, if you've heard of them. I think they come to Colombia as well. I went with them to Mexico, and I did notice that surgeons in other countries and other parts of the US have much lower density constructs. And I think it's just that at our institution, and Dr. Lenke is so fast at so safely placing all of these pedicle screws. For him, it makes sense to place screws at every level, and to maximize correction. Having screws at every single level, you can really derotate a patient. Typically, his approach is screws at every level and PCOs one level below UIV and one level above LIV, so that you can really derotate a patient and really correct them well. I think that that's part of the trick, having high density constructs to correct your patients. But frequently in the concavity of the proximal thoracic curve, it's hard to get screws in there, and sometimes it's just not worth it. It's not worth the risk of having a lateral screw that's close to the trachea or close to the aorta. So for this patient, this is intentional, that this type C pedicle that's up at the top didn't even attempt to put in a screw. And I'm pretty sure that the screws up here are actually juxtapedicular screws at T3 there on the right. So but I don't know that it really affects LIV or UIV for us. I think that it's important to, especially around your LIV, have a high density screw construct. I don't know how important it is at your UIV, because we've seen studies that even just having hooks at your UIV can actually, I think it was Dr. Newton's study, that having hooks for your UIV actually lowers the rate of PJK. So I don't think it matters so much proximally, but I know that the screws close to the LIV, having good screw purchase in all of your screws is really important to prevent distal adding on, to prevent your rod pulling out, set caps popping off. You want to have a good high density by the LIV. But I don't know that it changes your LIV selection so much. Maybe intraop, it could be a problem if you can't get a pedicle screw in the level above LIV. But hopefully that answers the question. Thanks for bringing that up too. We do use high density constructs. It's very helpful for correction. It can really derotate patients.
And that's true. Here in South America, we try to use high density, but it's just about the price of the screws that is so much. But I prefer to use high density, but sometimes it's difficult. So if I can, I use high, but the vast majority of my surgeries I use low density, but it just because the cost.
That makes sense. I experienced that too when I was in Mexico. I couldn't believe how much it cost for individual screws. It's our insurance system really covers these cases pretty well, and it isn't so much of a problem for patients and for surgeons. So we're very blessed for our system. But that's a big part of what Global Spine Outreach does. Is a lot of the companies, Nuvasive sponsored the trip I went on. They donate a bunch of their screws, rods, instrumentation systems so that you can use them abroad. But that totally makes sense. You have different goals: cost preservation, safety, and maybe having the most perfect alignment always isn't necessary. But you could see on this lateral here how the rods are almost overlapping for this patient. They really got a lot of derotation compared to their pre-op x-ray.
Very interesting facts, Dr. Pineda and Josie. So as per the literature, the screw density, ideal screw density varies from 1.2 to 1.8, so that you can have a number of pedicles. It's calculated by the number of pedicles divided by like number of screws divided by number of pedicles, and density of 1.2 to 1.8 is very standard. And the screws on the concave side are more important. The more the screws, the more the pedicle screw anchorage, and the more the rotation, as Josie mentioned, as well as the compression distraction is good. The more the anchors, the more the distribution of the construct, as well as the strength. So in that way, we can achieve better correction. But on the convex side, if we do the less screws, that also is helpful. So again, depending on various manuals, what manuals you're using, compression distraction, derotation, convex side derotation, the screw density takes a lot of importance. Also, depending on which sector you're working in, the public sector or the private sector, that's also one of the factors. But we always want the best of the best correction for our patients in the coronal as well as sagittal plane. And with the better screw density, you can also prevent the crankshaft phenomenon because you have the better control of the curve. So the anterior growth of the curve won't be possible in the little skeletally mature patients. So these are the few points about the screw density. You want to add something more, Dr. Coury?
No, yeah, that's a great point. The most important screws is the concavity of the major thoracic curve, and that's a big part of the Lenke technique, which there's so much that I could talk about, but that at the concavity screws that we really ventralize our start point, that we're taking off, the entire TP as much as we can to really ventralize the start point. So you can see that these screws are angled so medial. You can angle much more medial when you're more ventral, if you imagine it. So we have very long screws here at the apex of the concavity for this patient, and that's really able to, usually they're uni screws or fixed angle screws, so that you can really pull up and derotate the patient during your correction, which also straightens them out significantly. So yep, having high density around the apex of the concavity is really important for your correction and getting big long screws like these, you can see.
Yep. So just to wrap up before we wrap up, you prefer to do polyaxial screws at the end of the constructs and the monoaxial screws at the apex of the curve?
Exactly, yeah. And then the only other thing that we like to do is have a close head screw at one aspect of the construct, either the UIV or LIV, to have one close head screw just to hold in the rod. It's just it's a Lenkeism. We like to have that too. So, but exactly, use unis where you're gonna typically we use either we'll use just a double rod technique, or sometimes we use a VCM, the vertebral column manipulator, which really is helpful to connect to fixed angle screws or uni screws. If you have a poly screw, you can't use a VCM. So we usually put those at the fixed angle at the concavity, so we can use a VCM and really derotate and correct a patient. But yep, unis around the apex and then polys elsewhere if needed.
Sounds pretty good. So that ends we almost talked about for an hour, and it was really brilliant talk, Josie, and we really thank you for your time and accepting our invite. In the same way, we thank our OrthoTV studio, OrthoTV, Miss Poonam. She has been here. I think it's almost midnight, past midnight, around 2:30 a.m.
Thank you so much, OrthoTV. Wow, thank you.
And we also thank our mentors, Dr. Ashok Shyam and Dr. Neeraj Bijlani, for kind of giving the Ortho Studio time. There are lots of programs running around the same time, but we appreciate you helping us out here. Thanks again, and thank you. Thank you, Dr. Pineda, for joining in. Thank you, Dr. Hassan, and thank you, Josie.
Thank you so much. Thanks for the opportunity. Take
My
care.
pleasure. We can go offline, Poonam ma'am. I think we are not offline yet.
Oh, okay.
That's fine. It was brilliant talk.
Thank you.
Amazing. You did amazing. Wow. You almost covered all the important points and
Oh, there we go. Okay, now it stopped.
yeah.